Hey everybody, my name is Steven Salinger. I'm an officer in the Gonstead Club,
Hi, I'm Kayla. I'm an officer in training.
and we're going to be talking about how to integrate the 5 steps of the Gonstead system of analysis into the cervical region specifically. So that's the immediate case history, visualization, instrumentation, static and motion palpation, and then you always want to have X-rays. So whenever we're doing a case history initially, and a patient comes in and they're giving you some of their symptoms and some of their problems, just like we talked about in the other integration videos, you want to be thinking, which system is this in? Either sympathetic or parasympathetic. Now today, since we're focusing on the cervicals, we're primarily going to be talking about parasympathetic possibly, because remember C6 to occiput has been found to be parasympathetic, and then C7 down to L5 sympathetic. L5 is the mixed one, and then the sacrum and pelvis is parasympathetic. So the only other one we're going to take into account is the atlas. As it can rotate, it could be sympathetic or parasympathetic as well. All right, so some of the issues that somebody could experience when they have a subluxation in the cervicals, lower cervicals could cause issues with maybe going down the arm, some pain there, numbness, tingling, anything in the cervicals could affect the eyes, ears, nose, throat, any of those issues. And what's going to be unique about the atlas and the occiput is because everything comes out of those two bones first, everything in the brainstem, and then the vagus nerves run down next to the atlas TPs. You could actually experience symptoms globally or symptoms somewhere else completely away from the cervicals based on how those bones might be misaligned. So these are the things you want to think about whenever you're taking your case history. You want to make notes of all these and keep them in mind as they're giving you more details about what's going on with them. All right, so now we're going to talk about visualization. Visualization is going to be done throughout the whole process, but we're going to talk about it here in isolation for the moment. All right, so the most common things you'll see with visualization is hypertonic muscles, the paraspinals on either side, maybe redness in the area. You might be able to see a pocket of edema over a spinous process or over a region. You might be able to see skin blemishes, acne, anything like that on one side or the other, or isolated along a specific region. And that's going to give you some idea that there's definitely something going on there. It doesn't mean that's the subluxation, but that's something you need to pay attention to. Okay. Moving on to instrumentation, we're looking at the delta T here, or you have the nervoscope. So with the cervical region, you want to keep the probes wide. You don't want to bring them in narrow. This is going to be over the bones and not over the nerve roots. What we're looking for is irritation and nerve pressure over the nerve roots. So for the cervicals, we need to get wide, depending on the individual. Okay. You can start in the lower or the high setting. The higher setting is recommended right now. All right, so whenever we're scoping, and the cervicals are moving 2 closer to 3 seconds per inch per segment as well. And when we start, we're starting, if this is C7 right here, we're going to start at T1 or T2, because when we see that break, we've already passed the nerve root. All right, so here we go. Keep the probe, keep the delta T parallel to the spine, and keep the probes sealed over the skin. All right, so we're moving slower up the spine. And again, we're following the curvature of the individual's neck. So we're not just keeping it straight out and just pressing harder to keep it sealed. We're trying to keep it parallel to the spine. And if we do see a break, the nerve root and the cervicals is going to be inferior to the spinous process, okay? So if I see a break right here on the left, and I'm palpating, and I think it's C7, if I'm palpating C7 down here, this nerve root is actually above the bone, so actually I gotta move up to C6. So keep that in mind whenever you're palpating. Something that can really throw off the scope readings is hair in the way. So whenever you get up to the hairline, that's typically gonna be probably C2 and up, C3 and up on most people. You wanna maybe press a little bit harder to get some of the hair out of the way. and run that scope a few more times to make sure that you're not getting hair in the way and you're seeing what you think you're seeing. Now, whenever you get a break up there, you're going to want to palpate occiput, atlas, C2, because the break's going to be so close in there and you might not be able to tell exactly where it's at. So you're going to want to palpate all three of those. And again, remember to keep the probes wider and move the scope about 2 to 3 seconds per inch. All right, so now let's talk about motion palpation and finding where that restriction's at. So a couple common mistakes people make is they press too hard with the tips of their fingers. So what that's going to do is it's going to deaden the sensors in your fingertips, so you're not going to be able to feel as much. That tactile sensation is going to be worse for you. And then if the patient does have acute pain there, you're going to get a reaction from them, which is going to be to tighten up and the body's going to get in a little bit of a defensive stance, and it's going to make it harder for you to find where that restriction may be. So you want to try and be light, okay? So as with every segment, we're finding where the spinous is at. We're trying to get under it, all right? And let's see, I'm on that C6. All right, so let's say I found something at C7, so I'm palpating C7 and C1. All right, so she's in neutral right now. If I move her, I already feel it's starting to move right there. All right, so another common mistake people make is they're trying to feel where the whole range of motion is at. Like right about here, I can feel her muscle starting to tighten up and react. You don't need to go that far. You just need to go as far as you can until you feel that first initial restriction of movement, or or where it's moving compared to the one below. All right, and that's what we're looking for. Is you're not looking for where the full range is capable of. You're looking for where the restriction is at the beginning of the movement. It requires very little effort to get that. Okay. So right about there, it starts to move. Small movements is all you need. All right, same thing with rotation and lateral bending. All right, so right about there, it starts to move. Moves a little bit more this direction. So that'd be something like a PL. And then for lateral bending, again, it's very small movements. So this would probably be a PLI is what I'm thinking here at C7, okay? Whenever you're keeping these movements, whenever you're moving the patient through that range of motion, be conscious of how they're acting. If they're getting defensive in a certain movement, maybe want to pay attention and on or be more careful whenever you're moving them to that side. Maybe there is some serious issue there, but so let's say we found the PLI. We want to find out where that disc is most inflamed at. Okay, so you're going to move it into a motion that would mimic the correction. All right, so if we have a PLI, all right, it's going to look something like this as far as the correction. Now what I'm going to do is, it's called cutting the pie. Rotate and laterally bend toward that side, and then move through the different degrees called cutting the pie, and figure out where it's most restricted. So I feel it really restricted right there. All right, so this may be, that's going to tell me that's probably where her head's going to be positioned for the correction. So it can really help you get specific with your correction, which is what we're always trying to do, and get real specific with your subluxation.
Okay, now we're going to discuss X-rays. So one of the most important views that we're going to get is our lateral view, and that gives you your first letter of your listing, which is posteriority. So if it is misaligned or subluxated, one of these pieces is going to go back, and you're going to see that with the posteriority. You can also examine what's going on in between each vertebrae, because you'll see the disc space. So in the Gonstead system, we have a D1 through D6, and that gives you a good idea of the health of that specific disc space. So that's a really good thing to look for. You can also check for osteophytic changes such as smorals, nodes, the osteophytes coming together in the front, or anything else that you might see. There's 10 different ones, so reference your list. The next view that we're going to have is your A to P view. So that's going to give you your laterality and your wedging. And then the last one is going to be your A to P open mouth, which is going to give you your reference for whatever's going on with the atlas and the occiput.
All right, guys, my name's Steven Salinger.
And I'm Kayla Willoughby, and we're going to sign off for the day. So thank you for joining us for this club meeting. See you soon.